I am Dr. Dhiman Kahali, Senior Consultant Interventional Cardiologist, PM Birla Heart Research Center. And I have with me Dr. Ajit Mullasari, who is a very known figure and he is a great cardiologist, and he has introduced the STEMI system all over the Tamil Nadu. So Ajit, we see in our country that patients have heart attack and they think we have gas, we have acidity, and they take antacids, pantoprazole, ranitidine, etc., and they come much later to us. Even concerning us, the doctors, we are sometimes little reluctant to send the patients early to the hospital where there is cardiac facility and it can be done quickly and in an effective way. So after implementing the program in Tamil Nadu, how do you feel that anything more can be done about it in Tamil Nadu, and I am talking about the greater Indian perspective, that how we can introduce, because Create registry, Kerala registry, everything have shown that the patients come to us average more than 6 hours, 5 to 6 hours after the onset of chest pain. And our experience is that sometimes they come even later, means after 12 hours, after 24 hours, and European Society has therefore recommended that for primary PCI you can extend and go up to 24 hours, or if there is ongoing chest pain you can go up to 48 hours or even after that. That's a class 1A or 2A indications. So what is your message to the doctors, to the patients in general, that what should they do to know about the disease and to subject them to the medical care as early as possible, that is during the golden hours as we call it?
Thanks, Dhiman, for that brief issue-based discussion you had. The first part of the area is the recognition of chest discomfort, and this is a global phenomenon. It's not an Indian phenomenon. People tend to believe that they don't have a heart attack, and even among the doctor community they seem to underplay the symptoms. So this has to be addressed by a large public health effort, which is basically speaking about the problem that symptoms that look like gas are not necessarily gas, it's heart attack. You should go to a hospital. But what I have to say, that's the most difficult part of the whole thing. The American Cardiac Society and the AHA, along with the government of the US, have spent billions of dollars, but not been able to reduce the time from the discomfort start to access to a hospital to less than 120 minutes. European countries have brought it down much lower, but in the US it still hovers around 100 to 120 minutes. So I think that's one part of the story. But once somebody has chest pain and calls for an ambulance, in the Westernist society you will have the ambulance coming in about 5 minutes, an ECG taken, and treatment initiated immediately. What in this country we do not have is this system of care. So what we did in Tamil Nadu was basically got what we call as, now called as the STEMI India, or the hub and spoke model, where there are small hospitals which are surrounding big hospitals. The small hospitals could be small healthcare clinics, could be small government hospitals, could be district hospitals, which have a basic ability to do an ECG, and some of them will have a coronary care unit. So what we have tried to do is a public health sort of initiative of trying to disseminate the knowledge that if people have chest pain, please access a hospital. Once you go to the hospital, then once an ECG is done, then care is immediately started. The blood thinners like aspirin, clopidogrel, statin is given, and then if the patient can be shifted to a bigger hospital within 30 minutes, which is not usual in this country except in parts of India, you will thrombolize the patient, which is the best way to treat these patients. And once the thrombolysis is initiated, then you immediately start thinking of shifting the patient to a major facility.
At this point, just I am intervening. Have you got any fascination for any particular thrombolysis? That means streptokinase or the newer generation like tenecteplase or retiplase, and what difference you have found? Is there any difference so far as mortality is concerned? Because there is a huge difference in the price of streptokinase and the newer thrombolytic agents.
Well, if you look at the clinical data with thrombolytic agents, the greatest advantage of the newer thrombolytic agents like tenecteplase and retiplase is the ease of giving the drug. You can give it within a few minutes to 20 minutes. So that is the big advantage of this newer therapies. With streptokinase, you have to start an infusion, you have to give up, over 1 hour. There are many side effects, especially due to the anti-streptococcal antibodies in the system of many Indian patients because they are subject to streptococcal throat infections and you may get hypertension and stuff like that. So I think that the real advantage, more than mortality, has never been proved to be beneficial except in the gusto where there was a mild advantage of TPA over streptokinase. Over the newer thrombolytic agents, we don't have head-to-head data. But end of the day, what's most important is that the ease of delivery, I think, is the single most important thing. And number two is the level of arterial patency. It has always been shown that newer thrombolytic agents have higher arterial patency than the older thrombolytic agents.
But the funny thing is that it's almost double. For streptokinase, it is 32%, and for newer ones, it is 62 to 63%. That means just double.
Right.
But what is amazing is that it has not been translated. This superiority of the newer thrombolytic agents, so far as creating the patency of the infarct-related artery, has not been translated into reduction of mortality. So, any comments about that? Really, we do benefit from the newer thrombolytic agents.
Yeah. So I think that this is a very important subject, and we assessed this in the Tamil Nadu STEMI project. We had the impact of a single thrombolytic.
What do you give over there as a routine, or majority of the patient, what they get?
Well, right now in Tamil Nadu, when we ran the project, it was still streptokinase because government had funded 96% of the thrombolytics used was streptokinase. But now we have some data of streptokinase versus retiplase head to head, and we are hoping that the governments will move the second generation or the third generation thrombolytic agents into the government patients. The private patients obviously access because they can pay a better thrombolytic agent. Right. But I have to say that more than the type of the thrombolytic, it is a system of care which is important, because we published this in Indian Heart Journal that if you deal with streptokinase with a good system of care, you can almost get the arterial patency which you would get with the newer thrombolytics in terms of TIMI flows and arterial patencies. So what my take home would be that thrombolytic agents are important because if the newer ones can be given quicker, but more important, if you give a newer thrombolytic therapy but without a good system of care, you will have the same disadvantages.
European Society tells that give fondaparinux along with the streptokinase. What is your opinion?
Well, we have followed very simply a concept of whichever heparin you have and can afford and get. The advantage of say enoxaparin over fondaparinux, you don't need to change it in the cath lab, because fondaparinux unfortunately in the cath lab has not shown to be a great drug.
But strangely, European Society has not recommended enoxaparin, probably because of the fact that both together will increase or enhance the chances of bleeding. So fondaparinux being a weaker anticoagulant, they want some antithrombin action in a lighter way. Maybe that's their recommendation.
Maybe that's one reason.
Because they are very clear that use fondaparinux and not enoxaparin.
Yeah, but the data with extractomy was otherwise.
Along with tenecteplase, you can give enoxaparin.
Yeah, I don't think this really matters, and I think what really matters is give a good thrombolytic, give it quickly, and get the angiogram done quickly. That's my take.
Even pre-hospital thrombolysis, if possible, which we are attempting to do from our STEMI Society of India, we are trying to do that. So I think that will help further, because the CAPTIM trial and the French registry both have shown that if we thrombolyze the patient within first 1 to 2 hours, the mortality is even lower than primary PCI.
There are some issues of that in this country because of the legal issues. In France, where it goes on as a pre-thrombolytic system in the ambulance, there's a physician in the ambulance. Unfortunately, in India, we can't have physicians in every ambulance. So the legal issues will have to be covered before you start pre-hospital thrombolysis. But end of the day, I think the most important take is quick patient to access hospital, get an ECG within 5 minutes, thrombolize with a superior thrombolytic agent if possible, and following that in the next few hours shift to a tertiary care, because the complications moment they run in can create problems in small units, and have an angiogram done if possible within 24 hours so that you can access what is the risk to the patient and then plan. To just give you a brief, that in the Tamil Nadu STEMI project of 2,400 patients, before we put the system together and after the system together, which was published in the JAMA, we found a 3.4% absolute reduction of mortality, which is a tremendous reduction for a small group of population of 2,400 patients in the Tamil Nadu STEMI project, by just putting a system together. Everything else being the same, just putting a system together helps you. I think that's what we need to focus on. We need to have ambulance services, we need to have ECG facilities, we need to have good drugs in the periphery, and if possible, refer for an angiogram quicker.
Ajit, what can we do, you think, to increase the awareness among the population? Because at individual level, we have been going to TV, to print media, to radio, to different forums. We are telling, please don't ignore, consult your doctor, rush to a center where there is a good cardiac facility to reperfuse you if you have a heart attack. But still we find that our endeavor is too inadequate. So how do you think that we can increase the public awareness so that they come sharp within 1 to 2 hours, as it happens in Western society?
So one is the cost effectiveness of these public health motives or attempts. Giving a television show or putting up a huge ad is hugely expensive, because for a few minutes you may be paying lots of money, and it doesn't make that impact for the money put in. I would possibly, we in Tamil Nadu, what we are doing is very simple things. We are not spending too much money. Each primary health center has small put-ups which have in the local language in Tamil of how do you sense a heart attack, what do you do if you have a heart attack, where to go for, simple things for people. We could also use cell phones, because just giving SMSs are cheap, and we could use it in a way which is educative. This doesn't cost too much, rather than too much of high branding advertising, which would be not cost effective in my opinion in the long run. It has not proved effective in the United States, so it's unlikely to be proving effective in India. I think the Cardiology Society, the API, the Association of Physicians of India, and organizations like STEM India should take leads in putting all these actions together so that we can have a focused way of improving the access to myocardial infarction treatment.
So, do you postulate pharmaco-invasive approach, that is what you told just now, thrombolizing the patient as early as possible, and after 2 to 24 hours according to ESC guideline, we should take the patient to a hospital where there is facility for angiography and if required angioplasty, what we call as pharmaco-invasive angioplasty. So what is your experience that this pharmaco-invasive angioplasty is non-inferior to the other one, that is primary PCI?
I agree with you, Dhiman, that we have to have a resource-based treatment for myocardial infarction. Even in the US, parts of the US do not have access to cath labs, and they thrombolize patients. So there's nothing wrong in that. So I think the first thing is, from no treatment get to some treatment. From some treatment get to patients getting thrombolized. Once the thrombolysis is over, to try to get a pharmaco-invasive approach. And if those patients can get primary PCI, please go ahead and give it, because that is definitely the standard of care, but most people cannot access it in India. So there's no point saying something which is not possible to get. So I think these are the issues we need to look at. At this point of time, except for a very small group of patients, which are the cardiogenic shock or the patients with hemodynamic instability, where primary PCI is superior to pharmaco-invasive, with half-dose thrombolytics, safer antiplatelet therapy, a radial access, pharmaco-invasive to me is non-inferior to primary PCI.
I have two more questions to you. Number one, what are the hurdles in your working atmosphere? Because you are having an innovating new concept which is not new globally, but so far India is concerned, none of our states have such a STEMI program, which is a very active one, and you have successfully implemented it. Now, during the last few years, what hurdles you have really faced?
Well, I think the first thing is to get the government together with you. I think that it's very important that you have a public-private partnership and not do it in only the private system, because we know in the private system things are more efficient and the load of patients are much fewer than a public system. The second thing is to convince the government that investing in this, now we have a paper now coming in Global Heart which shows clearly that for every rupee that the government of Tamil Nadu invested, by improving the STEMI program and reducing the mortality, 3.4 rupees it saved. So it not only saves lives, it saves money. So once you say that to the governments, then they get involved more actively in the program.
And Ajit, how do you look that we have been working together that to implement this Tamil Nadu STEMI program to pan-India level, to all the states of India, so that all Indians can get this facility of this thrombolysis early and then pharmaco-invasive or PPCI, some sort of reperfusion, some sort of good treatment after a heart attack.
I think what we need to do is spread the message among physicians, that is one. Two, spread the message among the governments and the administrations that this is important, because this is a very clear acute problem which if you do it properly you can save a lot of lives. The third thing is to tell the governments that this is not very resource intensive. You can put this program in at reasonable cost, get a system of care together in the country, and get the Cardiology Society of India, the Association of Physicians of India actively involved in each state in trying to push this program to every part of this country. And I'm sure it's the same which happened in the US, it's the same which happened in Europe, and the same thing is going to happen in India, albeit it's getting a little slower and a little longer in this country than many of them.
I think even in USA, like in North Carolina, one very senior physician was telling in one of the HA meetings, I was chairing the session, he was telling that even there 20 to 25% of the patient are not reperfused. So this is a global phenomenon. Correct. But I think the smaller European countries are much advanced, like the Scandinavian countries, Belgium, France, Germany. Even on a snowing night when it's snowing heavily, they can go to any center within 30 to 40 minutes and get the primary PCI done. But our environment is totally different. So we have to work together and very hard work with the government, with the secretaries, with the ministers to implement this program. So how much hopeful you are that after implementing successfully in Tamil Nadu, we can implement it in a pan-India level?
Okay, so let me tell you the successes. So we have finished the Tamil Nadu phase 1, completed 2-year follow-up. The Tamil Nadu government is going into phase 2. That means they have put up 12 public hospitals with cath labs, which is very important for the public system to improve. And they're doing the same model of a pharmaco-invasive plus minus a primary PCI in all the hospitals. STEM India is partnering it. The Gujarat government has sent us an MOU for the first Untitled hospital with all its spokes. It's a government hospital with all its spokes. There seems to be interest from the Madhya Pradesh government to put this program together. And I think that all the cardiac societies seem to feel that this is good, and the implementation is just a question of time that we all put our heads together and get this going, because I think this will benefit many people in the treatment of STEMI.
And what about mortality? You were telling that mortality has come down significantly. So what is the present mortality at the level of the government hospitals or even in the private hospitals?
So in the Tamil Nadu STEMI project, what was very interesting to know was that the immediate in-hospital mortality was about 6.8%. But the 1-year mortality, if you did not put a system together, was about 19%. And if you put the system together was 15.6%, about a 3.4% reduction. But we have just finished the 2-year follow-up and it's close to 21%. So 1 in 5 people with myocardial infarction in India will die in 2 years. And this is very important things for people to understand. And this could be because the access to care is not quick. You will end up with a myocardial dysfunction. You may have medical treatment with the medicines not being appropriately taken by patients. So many things. So I think it's not only about the thrombolytic and primary PCI. It's about bundling the medical treatment along with it. But the harsh fact is that people are younger with MI in India. They have poorer outcomes in hospitals. They have later presentations. Their 1-year and 2-year outcomes are much worse than European and American patients. So I think it's a time to wake up.
There is a huge gap between the American and Euro Heart survey where the mortality has come down to almost 4.5 to 5%. Even they have improved, but some of the East European countries have not been able to reduce the mortality like that. So that is a stumbling block. Even after so much of hard work, the mortality is still high, and it is at an unacceptably high range. So we have to fight together to reduce the mortality. We have to increase the awareness among the population, awareness among the doctors, among the government secretaries and other level, so that we can implement this program very, very successfully under the leadership of Ajit and Thomas. He is not here today, but he is also very active, Thomas Alexander. I really congratulate both of you and all your colleagues for being able successfully to implement the program in Tamil Nadu, and we are vying to implement it from Cardiological Society of India and your STEMI India joint venture to implement it throughout India.
Thank you very much.
Thank you very much, really, Ajit.
Thank you.